All right, next talk is Alekos Theologis, who is our rising star at UCSF. He's going to talk about three-column osteotomies versus posterior column osteotomies for thoracic kyphotic deformities.
All right, thanks, guys. So this is just general principles, and won't take too much time because we'll want to get to the meat and potatoes, which is the cases. So disclosures, none of which are relevant. Thoracic deformity, 1,000-foot overview, is any malalignment of the thoracic spine, upper thoracic, mid, or thoracolumbar junction that results in functional disability, either from pain, neck, or back, neurologic impairment, and difficulty doing activities of daily living. There's multiple reasons why this may occur: idiopathic causes, congenital, traumatic, infectious, post-surgical. Iatrogenic is probably the most common. But here's good examples of the variability. So cervical thoracic deformity, young woman from Mexico, congenital kyphoscoliosis of the upper thoracic spine, iatrogenic, so upper thoracic kyphosis, PJK, and also distal junctional kyphosis. The mid-thoracic spine, again, huge amount of variety and variability, idiopathic scoliosis, multiple compression fractures from osteoporosis resulting in hyperkyphosis of the thoracic spine, infection, coccyomycosis, and then again, the proximal junctional kyphosis. But it falls under the umbrella term of adult spinal deformity, which we all know jeopardizes functional quality of life. And the cervical thoracic deformities are particularly disabling. A beautiful study from Chris and the ISSG looking at the relative disability to other chronic disease states, and this found that cervical thoracic deformities are worse than being blind. Frailty, picture of Chris's, thank you for sharing it. These are deformities that result in significant energy expenditure. Maintaining an upright posture results in high energy, and they present like this: significant frailty. This is compounded by their concomitant osteosarcopenia, and all in all, this creates for a very challenging situation. This is a patient that's upcoming with Erin, a lady who had this long thoracolumbar fusion, and you can see how frail and cachectic she is with screws obviously protruded through her back. And this is a lady who's been now optimized over 3 to 6 months or so, feeding her through alternative methods. And it really speaks to the fact that these patients need to have preoperative optimization. Prehab is key before undertaking these. Additional challenges of kyphosis. So spinal cord tenting is one of the challenges with kyphosis in any parts of the thoracic spine. As you lengthen the spinal cord, it changes its shape, and this results in demyelination and causes myelopathy. Management of these deformities, I think there's limited utility for non-surgical management. For operative approaches, really it's aimed at correcting the deformity. This will help with pain relief, improve their posture and cosmesis, and then again, addressing the spinal cord compression will improve their neurologic function and overall function. Big picture surgical options for the flexible, unfused posterior column osteotomies, if it's a more severe deformity, 3-column osteotomy, and for the rigidly fused ones, a 3-column osteotomy is needed. We've covered this relatively basic concept. Posterior column osteotomies involve removal of the facets, the ligamentum flavum, and then through posterior column shortening and a little bit of anterior column lengthening through the disc, you can get relatively nice correction. 3-column osteotomies, 2 types, PSO, and then the higher grade vertebral column resection. So an ideal candidate for a PCO are those that have open discs. The deformity is relatively broad. It's not focal. It's not over a single apex. So this is a nice example of a Sherman's kyphosis, multiple posterior column osteotomies. This is a patient, again, that I showed before, thoracic compression fractures. And looking at the supine imaging, MRI, as well as CT scan, look for open discs in the area that have fractures. If it has a non-union, clefts, as you can see through that yellow line, that white signal, that's a sign that there's a non-union there. And these are all nice things that will help you correct it without having to do a 3-column osteotomy. So this is a lady who we extended up to the upper thoracic, or we did a upper thoracic to pelvis fusion. And just with cantilever techniques, pushing down, we're able to distract, and that anterior column opened up significantly. Another example, a patient with proximal junctional kyphosis, again, assessing the rigidity at the proximal junction is key. So it has some improvement just lying down. It's rigidly fused actually in the posterior to the facets, but you can see that the discs are still open there. So in this woman, she was 80, 82 years old. We were hoping to avoid a 3-column osteotomy, and so we were able to do something similar, instrumented it above, and then through a cantilever technique, aimed at correcting the focal kyphosis after doing facetectomies, we're able to open this up. And in some ways, it's almost like a traditional Smith-Peterson osteotomy, where you have length of the anterior column and stretching. And overall, she liked her posture. The ideal candidates for VCRs, this is a different subset. So the fully rigid, no open discs, the severe and sharp angular deformities over a single level. And then I do think that if there's significant ventral compression from the deformity, then having neural decompression is advisable. So this is a lady, actually SIG asked me to take care of this. Thanks, lady from Poland. She was a SRS a charity case. She had about 18 spine surgeries, multiple infections, and prior spinal cord injury. And she presented with this progressive idiopathic congenital kyphoscoliosis. Her CT scan, a 3D rendering of it, showed that she was rigidly fused except through the apex. And this is a lady who requires a vertebral column resection. Even though her discs are open, releasing it all from the back and trying to correct it probably is not going to work. So this is just intraoperative examples of doing the multi-level VCR, and overall she corrected nicely. I have Zoom visits with her every year from Poland, and she's doing quite well. This is a lady, Erin, you remember this guy, 3-level coxy, and with this degree of ventral compression and kyphosis, this is not a case that you're going to achieve with posterior column releases, plus you have to debride the anterior column for infection purposes. Really focal, sharp, angular deformity. You can see the gibbous deformity lying down. It's a rigid, releasing it and taking out the anterior column, shortening and reconstructing it with a expandable cage. Cleared the infection. Actually, his neurologic exam improved in the hospital and came in not walking and left the hospital walking. This is the lady before, previously fused in situ in Mexico from T3 to 5 with this very rigid kyphoscoliosis. And preoperative planning is very helpful for these, 3D modeling. Again, fused, and so this requires a VCR. Some intraoperative photos just showing how we set this up with cervical instrumentation, and then using a stabilizing rod and do all your work around it, and then through a variety of different maneuvers. After doing the 3-level VCR, I think we're able to correct her acceptably. This is a lady we did a couple weeks ago, McCune Albright. She had a upper thoracic to lower thoracic fusion, and because of her bone pathology, she slowly kyphosed above, and she was quite rigid. This is her intraoperatively, and then again, we had to do a 3-column osteotomy to correct this through a T4 PSO. Now, I think those are the blacks and the whites. There's definitely the gray. So commonly we experience PJK, and not always is there a very significant fracture. There may be a subluxation, but in a person like this who has open discs, the question is, what do you do? PCO versus a 3-column osteotomy. I think I know what Ames and Devon would do. I take a different approach. But anyways, I think that with open discs, I try to release the spine at each level segmentally. In these, I've been burned by C8 palsies, and so I'll definitely do a decompression at C7, T1, wide facetectomies, and then Ponte osteotomies at every level. And then through a cantilever maneuver, I think if you can correct that T1 slope, they can be realigned without a 3-column osteotomy. Similar case, and again, I definitely could do a upper 3-column osteotomy at T3, but again, we try to take advantage of the disc space being open. So Smith Pete's or Ponte's from C7 down to T3, and again, cantilever for these, it tends to work out quite nicely. Chris and All also did a nice comparison looking at PCOs versus 3-column osteotomies for their cervical thoracic deformities. And you can see the major findings there. No significant difference in complication rates, but there were absolute surgical and neurologic complication rates were higher for the 3-column osteotomies. But I think ultimately you just have to dictate your surgery based on the pathology. Another review not showing one is better than the other. I think it really has to be tailored to the deformity. Now, this is an interesting case. We talked about Sherman's before, rigid. This lady has developmental delay. You can see that she has autofusions of every disc space, and she also has ossification of ligamentum flavum at every level. She presented with worsening bowel and bladder because the kyphosis was thinning out her spinal cord in that mid to upper thoracic spine. So we thought, well, maybe we'll do a 3-column osteotomy, and we had planned for that. But we did multiple PCOs, decompressed it, and then we used a very rigid rod, cantilevered, and during the operation we heard a couple snaps, and the position looked better. And we got an intraoperative CT scan, and we found that we actually had created osteoclasis through a couple levels, and that was, again, a traditional Smith-Peterson osteotomy, opening the anterior column. Didn't have to do the 3-column osteotomy, and overall her clinical, she was improved. Sorry, some of the x-rays didn't show up. So kyphotic deformities of the thoracic spine result in severe functional disability. Surgical corrections aimed at restoring adequate alignment. PCO versus 3-column osteotomy, I show the ideal candidates for each, and preoperative optimization, nutrition, physical therapy, mental health, et cetera, is probably the most important thing for these. So thank you.
All right, so we can have some questions about the PJK, prevention techniques, and the osteotomies for thoracic kyphosis. So I have a question for Mike. You kind of presented really nicely about the prevention techniques, the vertebroplasty, hook, ligament repair. And my question is about, like, based on Shane's data, when you look at these patients, like when they're getting out of the chairs, they are leaning forward. There's significant moment arm built on that junction. What can we do postoperatively? Because the muscles are stripped despite the ligament repair techniques. There is still not a good tension band for at least like this muscle kind of scarred down to the spine. And I'm not sure that the TLSO is really effective preventing that. Any suggestions? Lately, I've been using CTO, but I'm not sure if that is effective. Any suggestion for post-op? I've been using CTO. I'm not sure if there's anybody else's opinion. So I moved from TLSO to CTO, and I think it's easier to apply, and you can put them in when they are on the chair, and then when they are getting out of the chair, its kind of junction is a little bit protected for at least 6 months, 6 weeks.
I think getting out of bed is the most important. A lot of them do sit-ups when they get out of bed, and they break within minutes after their surgery. So I think we've really spent a lot of time teaching them how to roll out of bed, which is, I think, even more important than getting out of a chair. And then I just used a Jewett for most of mine, or an Aspen for the high thoracic. But I think the education on how to get out of bed from your physios and everybody is really important for this patient.
Shane?
So, one of the things that I've been doing, and I don't have any data, so I'm just going to share because that's kind of what this whole thing's about. So one of the things I've been doing is reconstructing the soft tissue envelope pretty robustly, and I'll take suture anchors like the number 2 fiber wire, wrap it around the rods, and at multiple spots throughout the thoracolumbar spine, suture the extensor muscle back down to the hardware, right? It really goes back down to the hardware, and it recontours the alignment of the muscles. It decreases the dead space as well. But I don't know, that soft tissue envelope adds kind of a secondary structure to it. And then the other thing I've been doing recently is using suture anchors at the top instead of like the tether that you're doing, but the suture anchors. So drill and tap the suture anchors in the top, and then tether that back down to the construct. And I think that we need to do more research on soft tissue balancing. Everything in orthopedics is about soft tissue balancing, right? And in spine, we don't talk about anything like that. And I think we need to look more into it.
Munish, I think you have the most deformity experience. Like, what do you do for PJK prevention? I don't think we can prevent it all, but we can maybe minimize it. So you're learning from all these surgeries. What do you think?
It's not zero. I think my rate of reoperation is significantly decreased. I learned from you guys about I do the tethering that you guys taught me. I do a lot of kyphosis bending on the top. And I don't tighten the top when I'm doing the correction. I let it sag and take up the slack, and then I just tighten where it lies. That's one of the tricks. So I do the fiber tape before I do the correction, and I do the correction. I don't tighten the top at all. And once I'm done with the correction, it kind of falls where it wants to, and then I tighten where it lies. And then, I do the BMP on UIV plus UIP plus 1. I sneak up the BMP up there to get like a
Soft inside fusion.
Exactly.
Yeah.
It's like a dynamic fusion. So my rate, now is about 15%, but revision rate is really small. So I get this a strict criteria of, there's some bend, but I think that's just the rigid portion meeting the flexible portion. So that's what I do right now, but it's very rare that I revise them now.
All right, any more questions before the break? Okay, seems like everybody's ready to take a break. So we'll come back like 10 minutes.
Yeah.
All right.